And now it is my honor to introduce the president of the American Heart Association, Dr. Stacey Rosen, who will deliver the Lewis A. Conner Lecture. Dr. Rosen is the executive director for Northwell's Katz Institute for Women's Health and senior vice president of women's health at Northwell. She's widely respected for her work in women's cardiovascular disease, focused on eliminating healthcare disparities through clinical programs, research, community partnerships, and education. She's earned many prestigious accolades, including the AHA's Physician of the Year Award and Women in Cardiology Mentoring Award. Dr. Rosen is a powerful voice for our Go Red for Women movement and a passionate leader for our mission. In every role, she's guided by her cardinal rule of doing what's best for patients. Please join me in welcoming the president of the American Heart Association, Dr. Stacey Rosen.
In the fall of 1992, at a hospital in New York City, 2 babies were born around the same time on the same day. One of those babies was a girl, the other was a boy. Genetically, we know the difference between them is only a single chromosome. Girls, of course, have 2 X chromosomes, and boys have 1 X chromosome and 1 Y chromosome. Beyond all the obvious ways this difference impacted the trajectory of their lives, their biological sex also put them on vastly different paths with respect to our understanding of their cardiovascular and cerebrovascular health. The boy would be the beneficiary of decades of research, prevention strategies, treatment options, and life-saving innovations geared to his biologic sex. The girl, not so much. Up until approximately the time those kids were born, it was believed that human hearts were human hearts and human brains were human brains. So the thinking went, scientists could study the hearts and brains of men and simply apply any findings to women. Why was this male-centric model of cardiovascular disease accepted for so long? In preparing for my comments today, I posed that question to many luminaries in our field. Considering that a key element in scientific innovation involves challenging norms, I wondered why no one had ever questioned whether sex could make a difference in the way cardiovascular systems function. The answer I heard time and again, we didn't think it mattered. Today, we will discuss when, how, and why we learned that sex does matter. And now that we know it, we'll discuss what we should be doing about it. The story of how cardiovascular science became male-centric begins in the 1940s. Instances of rheumatic heart disease significantly declined thanks to the therapeutic use of penicillin. However, a new problem emerged, a growing prevalence of myocardial infarctions. The risk factors and pathophysiologic mechanisms behind heart attacks were poorly understood. This prompted early calls for research. As a matter of fact, this is when the American Heart Association began funding research grants. Then, in the 1950s, a series of large population studies were launched. The aim was to identify risk factors for the development of coronary artery disease and ultimately to create prevention strategies. Of course, all participants in those studies were men. An exception was the Framingham Heart Study, which was initiated by the United States Public Health Service to investigate the epidemiology and risk factors for cardiovascular disease. The initial cohort from 1948 consisted of 5,209 men and women between the ages of 30 and 62 who lived in Framingham, Massachusetts. This study led to some important observations about women. First, women with type 1 diabetes had no advantage over men with respect to the ravages of heart disease, and they developed myocardial infarctions frequently. Second, women were more likely to have what we call silent MIs, when an infarction pattern is seen on ECG in women who do not have symptoms. However, the biggest news about women's heart health that came from Framingham turned out to be flawed. The study concluded that women didn't get heart disease. Yet, this wasn't a scientifically valid conclusion because that analysis did not include enough women with heart disease. So just when a major study finally took a look at women, this takeaway turned an opportunity into a setback. Then came the 1960s and 70s. Many important clinical trials were conducted. The Physicians' Health Study, Mr. Fit, VA cooperative studies, and others. Again, those studies included only men. These limited, population-based data led to what we now know to be incorrect observations and false conclusions. For instance, we were told that angina was more benign in women than men. We were even told that angina in women was not associated with adverse outcomes. Meanwhile, culture, taking a clue from science, spread the word that men have heart disease and women take care of them. By the mid-1980s, things were getting very interesting. It started with groundbreaking advances in care. New tools such as thrombolytics, stents, statins, and a new generation of implantable defibrillators truly were making a difference. We were finally beginning to see lower death rates in men. Because at the same time that heart disease mortality rates were going down for men, the same was not true for women. In fact, for the first time, more women were dying of heart disease than men, and worse yet, the gap was widening. All those years of studying only the hearts of men, all those years of either ignoring women or of presuming that women's hearts were the same as men's, had caught up to us. This graph was our wake-up call. Earlier, I mentioned that luminaries in our field said that it never occurred to them that sex mattered in the study of heart disease. Well, now the dichotomy was so stunning that finally it did occur to everyone. And soon, a series of important initiatives began. In 1986, Dr. Nanette Wenger led the first NHLBI workshop on coronary heart disease in women. In 1990, the NIH created the Office of Research in Women's Health, with Dr. Vivian Pinn named director the next year. Also in 1991, a publication by NIH director Dr. Bernadine Healy noted that women were systematically underdiagnosed and undertreated for heart disease. Subsequently, the first NHLBI conference on cardiovascular health and disease in women was held, and the seminal paper, Cardiovascular Health and Disease in Women, was published by Drs. Wenger, Speroff, and Packard. At this same time, extraordinarily large, randomized clinical trials were launched to answer important questions about optimal treatment of acute myocardial infarction, still without adequate representation by women. Historically, our field equated MIs with coronary occlusions. No occlusion meant no MI. So when a woman showed up in the emergency room complaining of crushing chest pain, and her blood work showed enzymes indicative of ischemia, but her angiogram, which was then the gold standard for determining an occlusion, came out clean, well, we had no way to understand this. The absence of an occlusion got her sent home with a diagnosis of heartburn or a muscle pull, or most distressing, being told it was all in her head. But as the 1990s unfolded, it became apparent that our understanding of coronary heart disease in women was incomplete. We needed more answers, and that meant we needed more trials to find them. One of the biggest randomized clinical trials at the time was TIMI. The first 2 iterations did not include data differentially presented by sex, perhaps because only 15% of those trial participants were women. Then came TIMI 3B. This iteration, published in the mid-1990s, looked at unstable angina and non-ST segment elevation myocardial infarction, and 34% of participants were women. Guess what this trial found? 25% of women who had myocardial infarctions had no obstructive lesions at all. Think of that. A full quarter of those women diagnosed with MI did not have what we historically equated with coronary heart disease. In the drip, drip, drip of progress, this was one of the first splashes. Soon it became a flood. A series of mega trials continued to show that a significant percentage of women with chest pain had no epicardial vessel obstruction. We initially attributed this to a non-cardiac explanation, but the preponderance of evidence compelled us to rethink some long-held beliefs and demanded that we develop new hypotheses. In 1996, Dr. Noel Barry Merz led the NHLBI study group that launched the WISE study to better understand diagnostic testing to evaluate women with coronary heart disease. These trials showed us across the spectrum of acute coronary syndromes that the mechanism of atheroma progression was sex differentiated. We also learned that our traditional diagnostic tests did not work particularly well for women. In the decades since, more studies have expanded our understanding of what is unique, different, or disproportionate about women's health. However, serious questions remain. Why do women with diabetes have a markedly different risk factor profile than men with diabetes? Why is it that women are 2 to 3 times more likely to have migraine with aura, which we know is a risk factor for ischemic stroke? Why are the mechanisms of sudden cardiac death different in women and men? Why do women have a 38% higher risk of mortality from CKM syndrome conditions compared to men? And honestly, this is just a short list of questions. So now let's talk about all this through the lens of those 2 children, born in the same hospital on the same day in 1992. As we've just discussed, they arrived when the male model was the default, and women were considered small men, or the atypical version of a man. They were in grade school when the Institute of Medicine report, Does Sex Matter?, came to the resounding conclusion that it does. As they became teens, researchers began asking questions such as, do sex differences exist? If so, what is the mechanistic or physiologic explanation? And how do these findings impact our ability to improve health for both men and women? As they became young adults, the answers to these questions began improving our ability to detect and treat a host of cardiovascular and brain health issues, as well as issues in cancer medicine, musculoskeletal issues, autoimmune conditions, and on and on and on. Now they are 33 years old. Should either develop any of these health problems, science is prepared to deliver more precise care that is more appropriate to their biologic sex. Don't you think that's great? I certainly do. I say that as the president of the American Heart Association and as the head of a multidisciplinary women's health institute focused on sex differences. Most of all, I say this because these 2 babies, born at the same hospital on the same day in 1992, are my children, Rebecca and Max. I'm proud to note that Rebecca and her younger sister have followed my husband, Dr. Mark Silverman, into the field of medicine. Becca is an ophthalmic surgeon, and Sarah is a clinical psychologist. Max, meanwhile, works in finance. While I'm on the subject of the people who mean the most to me, It has been said that you should find a group of people who inspire you, spend a lot of time with them, and it will change your life. I have been fortunate enough to have found so many of them at BU, Monty, Cornell, Mount Sinai, Northwell, and the Katz Institute. I want to give a grateful shout out to the Otter Raft. If you know, you know. I must mention my cherished friend, who is more like a sister than a colleague, Dr. Jennifer Merez. Lastly, to my family. My brother and I were raised by parents who modeled integrity, fairness, and giving back. My mother, Harriet, is my best friend and biggest cheerleader. My late father, Marvin's wisdom guides me every day. 40 years ago, in the CCU at Montefiore, I met Dr. Mark Silverman, and we've been together ever since. His support, encouragement, and sense of humor have made him my steadfast anchor and greatest source of strength. Together, we have 3 extraordinary children, and each of whom has a remarkable partner. These 6 amaze me and provide me the greatest source of joy, except, of course, for Mira Rose, my first grandchild, the light of our lives, the star of our family group chat, and the reason I continue my quest to advance women's health. One of the things I love most about science is the way our thinking evolves. As we've gathered new information about the impact of sex in cardiovascular disease, our lexicon has changed. Coronary heart disease is now ischemic heart disease. We've retired the term atypical to refer to symptoms mostly felt by women. We've evolved from congestive heart failure to heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. And then there's my favorite. We've evolved from does sex matter to how does sex matter? The next wave of progress is making that a foundational question in everything we do. If you are a basic scientist, how do you better understand the impact of sex hormones on cellular function, physiology, even anatomic differences? If you're a trialist, how do you better develop processes to include more women in trials and disaggregate the data? If you are a translational or implementation scientist, how do you address sex differences as you go from bench to bedside to community? If you're a geneticist, how do you identify epigenetic modifications associated with differential risk for important cardiovascular conditions? If you're a medical educator, how do you incorporate sex as a biological variable into all curriculum and all training algorithms? If you're a healthcare executive or economist, how do you leverage the economic benefits of addressing the unique health needs of women? If you're a practicing clinician, how do you factor in sex-specific differences when preventing, diagnosing, and treating heart disease? And finally, there's one more target audience I need to address. If you were born from a woman, this entire conversation is for you. For far too long, women's health has been considered the domain of women scientists and clinicians. And while there are more women in the world than men, we all know that's not the case in cardiology. So strictly as a numbers game, improving the health of women won't work without men. The women trying to answer these critical questions do not need men merely as allies. What we really need are men as advocates. Better still, what we need are men as accomplices to improve the health of hearts and brain of women. There are many ways I can make this appeal. The easiest is to remind you of all the women in your life. Don't you want the best science for them? Another approach is asking you to imagine if we looked only at women's hearts and presumed that men's hearts were the same. Seems preposterous, right? Well, then that reveals the fundamental flaw in how we have done it. Lastly, there's the notion of scientific curiosity. Don't you want to do science better? Isn't that why we're all here? And think of it this way, there is a lot of important science left on the table. That means there's a golden opportunity to make a name for yourself. Who among you is going to be the next lead author on groundbreaking science focused on providing better health for women? It all comes down to this. When you go back to work, in all that you do, ask yourself and your colleagues, how does sex matter? Thank you.